more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hello, South Florida and beyond, and welcome to the You and Your Doctor Living a Longer and Healthier Life show. We're going to be talking tonight about internal medicine with an internist and nephrology as well. It's the same guy. He does both. So nephrology is specialized in the kidneys. Very important. He's Dr. David Moskowitz from Hollywood, Margate, and Sunrise. Welcome to the program, Dr. Moskowitz. How are you doing?
Just fine. Thanks, David.
And thank you for joining us on this adventure of health, I always say, because we learned so much. I was just learning a whole bunch just before we went on air. But tell us a little bit about your specialty. So you're an internist. We know a lot about internal medicine. Nephrology fascinates me, the study of the kidneys. It's kind of more of a super specialized fact of medicine.
Well, I always thought nephrology was too hard for me. I was just going to be a gastroenterologist in med school. But as the nephrologists say, the GI tract is dumb compared to the kidneys. It just has a single nephron from the mouth to the anus, whereas the kidneys have 1 million nephrons in each kidney.
Unbelievable. How big is the adult size of a kidney?
It's about the size of your hand. It's, okay. A good one is maybe 7 inches long, and by the time you go on dialysis, they shrink to about 4 inches.
Dialysis. You don't want to hear that word. How can we keep people off of dialysis?
Well, dialysis, most people take dialysis in stride. There's a dialysis unit on the corner of every street. It's becoming almost like having Publixes or Walgreens. But the truth is that dialysis is a very poor treatment for kidney failure, and I don't think we should be complacent about dialysis any more than when people used to be complacent about iron lungs during the polio era. I think we should be working very hard to prevent dialysis.
To keep people off of dialysis so they don't have to, what is it, a few times a week they have to be hooked up to the machine and it has to run the system for them?
Well, so you get hooked up to a machine that's essentially a washing machine for your blood. And there's another variant called peritoneal dialysis where you do it yourself, and you don't involve blood, you just involve putting fluid into your belly, but you have to do that many times a day, 4 times a day. Most people choose to do hemodialysis at a center, although there's some people actually brave enough to try doing it at home. There are about 500,000 people on dialysis, and it's essentially a washing machine that is good for a few days, but you have to keep washing your blood every 2 days. And if you miss more than one episode, then you get very sick and wind up in the hospital.
Now, if it's not done by a certain point, can people actually die from it as well?
Oh, yeah. People routinely die from missing dialysis. If you choose not to go on dialysis, it's a way to die. I mean, it's either dialyze or die. It is literally life or death. The best treatment for kidney failure, if you have to have it, is a kidney transplant. That changes your life almost to normal. The problem is there aren't enough kidneys for the 500,000 people with kidney failure. There are 100,000 new people every year in the U.S. with kidney failure, and there are only 13,000 cadaver kidneys available. So most people just stay on dialysis. They wait 4 or 5 years. Problem is the average life expectancy is only 3 years. So you usually die while you're still waiting for a cadaver kidney.
Before I ask the next question, I just want to make a quick comment. We've had Dr. Stuart Himmelstein on this program a few times. He's an internist, and he actually has been on the search for a kidney. He needs a kidney transplant for, I believe he's in his 6th year now, and it's been tough. He's had a couple close, chances, but something at the last minute kind of, he was flown out to a couple places, kind of just didn't work out match-wise. So that's very important. Now that's going to kind of segue me into, I believe, my next question, which I want to talk a little bit about GENOMED.com and GENOMED. So it's applying genomics. I said genomics, but you corrected me. That's why I was already learning before we went on the program. But tell me a little bit about applying genomics to the practice of medicine.
Well, let's go home with the genome. Basically, if GENOMED gets its way, your physician who's looking for a kidney will have no wait whatsoever in finding one. We think we can prevent 90% of dialysis. We can prevent diabetics from getting kidney failure and hypertensives. And diabetes and high blood pressure cause 90% of kidney failure. Polycystic kidney disease causes 5%. And then the other 5%, which I can't do anything about, are a bunch of rare diseases, which are horrible, but fortunately not very common. So 10% of kidney failure I can't do anything about. But that's only 10,000 people a year if I can prevent 90,000 from going on the machine.
Most definitely, at 90%.
And remember that number 13,000 for the cadaver kidneys. So the 10,000 people who would still be going on dialysis, they could all qualify for one of the cadaver kidneys. They could all get a kidney transplant immediately. They wouldn't have to wait, and the country could be dialysis free. And that's what GENOMED wants to do.
And it's genomed.com, because I know people will watch the show at later times, maybe, and use it as a catalog of resources. All of our shows are on allcountyhealthcare.com under the radio tab, and their Facebook page, which is facebook.com/allcountyhealthcare. All of the shows are there. So definitely check out GENOMED. Now, if people want more information on GENOMED, just go to the website and they can connect with you there?
Absolutely. So just click on Contact Us, and it asks you for your email. That's actually all we need. There are other things that we ask for, but you don't have to supply them. And we've been taking care of people all over the world via email. So it's sort of a crude form of telemedicine. Mm-hmm. And in fact, we think that we can text people, because no matter how poor you are, you have a cell phone. No matter how rich you are, you have a cell phone. So we think we can take care of the 2 billion adults with diabetes and high blood pressure, basically from headquarters at GENOMED, and keep everybody that we need to off dialysis.
Again, it's genomed.com. So how are you able to help people maybe get towards that connection at GENOMED?
So the concept is simple. There are blood pressure drugs called ACE inhibitors that everybody's heard of. Enalapril was a popular one in the 90s. Captopril, people have probably heard of. Lisinopril, everybody's on now. The one that actually helps kidneys is none of the above, but it's one called Quinapril. And we basically found that out in 94, and also found out that the dose that people were using, and they're still using, 40 milligrams a day, is nowhere near adequate. And that if you go up on the dose by several fold, that you can actually reverse kidney failure. So even people with late stage disease, I used to think that we had to catch people early on, but it turns out that even late stage disease, just weeks away from dialysis, we can keep them off the machine for a year at a time, which is pretty good. If you're being told that you have to go on dialysis within a week or two, or else you'll die, and you get to stay off for a year and a half, maybe then you get more used to the idea of dialysis. It won't look so bad. Maybe by then we will have prevented more dialysis, and the wait for a cadaver kidney won't be so long.
Definitely, and again, it's genomed.com. How did you find this out about the quinapril? I mean, you've been an internist for a few years, right? You're a veteran internist in a way, year-wise.
I'm an old fogey.
No, I don't mean that,
retired.
but I'm trying to say how distinguished you are. You know, you've definitely done the research. You know, that
distinguished that kind of is not what my kids would call me. This break came actually using genomics. So in '93, I found this genomic variant that had been fully worked out by a French group, Pierre Corval and his lab. And it turns out that overactivity of ACE was associated with heart attacks. People who had this variant that gave them too much ACE activity of this enzyme had a 3-fold higher rate of heart attacks in a terrific paper they published in Nature. And too much ACE, well, ACE makes angiotensin 2, and it looked to me like angiotensin 2 could be important for lots of things. So we genotyped the VA hospital I was at in St. Louis and a dialysis company with 4,000 patients, and the city hospital in St. Louis with another few thousand patients. So about 10,500 patients in all. And we found that 2/3 of diseases in whites were associated with excess ACE activity, so that using an ACE inhibitor would actually, should help. Diseases that aren't even thought of in the context of an ACE inhibitor. For example, we've published better results for emphysema, which currently nobody's using ACE inhibitors for COPD. We published better outcomes for sickle cell disease because it looks like ACE is actually senses how little oxygen there is in the bloodstream. And when patients start sickling, when their red cells start sickling because they have sickle cell hemoglobin, the oxygen goes way down and ACE seems to be activated. Anyway, and the crisis gets worse. It gets amplified. All the vessels constrict, and a lot of red cells sickle, and it makes everything worse. It's a vicious cycle. We can break that with Mavic, another ACE inhibitor. So we use ramipril for COPD, Mavic for sickle cell, quinapril for renal failure. In general, it looks like quinapril is drug of choice for atherosclerosis, for preventing it.
Unbelievable. This is a very interesting interview this evening. Definitely learning a lot here. Again, it's genomed.com. Dr. David Moskowitz, internist and nephrologist. Margate and Sunrise, so Broward County, but the number is 954-586-8058, and definitely check out the website. Dr. Moskowitz, hold that thought. We're going to take a quick break, and on the other side, talk a little bit more about your practice and GENOMED on the You and Your Doctor show.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096.
Getting older is not for sissies. That's what one of my patients says. And it's funny, but it's true. Live long enough and you'll get arthritis, skin cancer, probably one of the common chronic diseases like CHF, COPD, diabetes. At All County Healthcare, we teach you how to manage your disease. We make sure you know how to take your medications and how to recognize signs and symptoms before requiring hospitalization, no matter how many visits it takes. You didn't move to Florida to be sick. You moved here to enjoy the rest of your life. And that's exactly what our team of nurses, therapists, and aides at All County Healthcare help you do.
You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Yeah, welcome back. I'm just fascinated about the content that we are creating on the show. This is amazing, and this is thanks to you, Dr. David Moskowitz, internist nephrologist, GENOMED.com. I started asking you during the break, but I want to save it for the listeners and viewers. How long has this been your focus? And you said early on, 1993, but even before you came to South Florida, tell us a little bit about how long it's been your focus, and then on about your education and training and what brought you to South Florida.
Well, I'm happy to be in South Florida, I have to say.
This time of the year, right?
Yeah, especially
Must
now.
be from the Midwest or something.
Absolutely. So I came from St. Louis.
Or the frozen tundra, they're calling it now.
Right. Back when I lived there, climate change hadn't turned it into a frozen tundra. And it was actually a pretty nice place to live compared to Boston, where I came from. So I went to school at Harvard College, and then I went to England for 2 years on a Marshall Scholarship and did biochemistry a second time, and then did biochemistry a third time in medical school at Harvard MIT. There's a division there for people who want to apply engineering to medicine, which was hard because I didn't know any engineering, but it was an interesting way to approach medicine, and I've come to appreciate the education that I had while I was there. After Harvard, I'd been there a long time, and so I felt like it would actually be better for me to leave. And at that time, the best internship and residency was at Barnes Hospital in St. Louis. So I was lucky enough to get in, which required actually some scrambling and politics. But that was actually the last time that I was good at politics, so I spent 7 years at WashU.
I don't know, you'd get my vote. I mean, I just met you tonight, but you'd get my vote.
Well, you're very kind, but the problem is you crossed me on a patient, and I'll fight you to the death. So they told me, I think you have to decide when you're in training, you have to decide who's going to be your master. Are you going to essentially suck up to your teachers and get good grades? And then later in academics, are you going to suck up to your bosses and sacrifice patient care? Or are you going to do everything you can for your patient, including being a pain in the ass to the administration? This is precisely what happened to me. So, in med school, we were told solve a disease. I was lucky enough to solve this renal failure thing when I stayed in St. Louis. I didn't want to go to the NIH, or I was tired of traveling. And so I put down roots in St. Louis, and I got a job at St. Louis University, couldn't get one at WashU, which was the origin of my comment that I had kind of maxed out on politics. And at St. Louis U, it was a very clinically oriented school, and I was at the VA, and my subject was renal hypertrophy. The idea was if I gave people the growth factor for their kidney, because if you take one out, if a donor donates a living donor donates a kidney, the other kidney grows, which is the only reason they can donate. And so I wanted to find out what that growth factor was, the renotropin, and give it to dialysis patients right before they went on the machine and make their own kidneys grow more. So it turns out, after 7 years of looking, that the growth factor for the kidneys is angiotensin 2, the product of ACE, and that it's not as simple as giving the growth factor, getting kidneys
Where
to
did
grow.
that eureka moment happen? Like after 7 years of that kind of focus, where did that happen?
That happened in there was something big that happened in 93.
Okay.
And at Thanksgiving 93, I realized that this ACE variant, that the ACE gene was not just involved with kidney failure, but was involved with diabetes itself and with everything. I mean, it was
an exciting time.
It was an Abrahamic moment. You know, it was like one gene. It's a master disease gene. It's not supposed to be like that.
Since then, how many people do you think you've helped out since then?
Well, I know exactly how many people
Okay.
I've helped, because nobody in healthcare has publicized this ever. So I've helped my own 4,000 patients, and that is it. And I could
Kudos to you. Thank you.
No, but consider, I beat myself up about this. Part of scientific discovery is getting the word out. It's no good if you discover something and can't publicize it. So there are at least 20 million people who've died on dialysis prematurely after an average of 3 years or less, who I could have saved if only my paper had gotten, just the usual press attention that it should have gotten. And instead, it's been suppressed. It has actually been suppressed by the healthcare
Yeah, but
community.
you went the extra mile for the patient. You saved 4,000 people who would have died. They would have had a worse quality of life. Their friends and family wouldn't have been able to spend more time with them.
Well,
I mean, that's the trade-off here. You've still done an amazing thing, and kudos to you.
This is just
Get that paper back out there. Yeah, I'm a PR guy. I'll get that out there.
This is the beginning. I feel like I've spent 25 years. It's been a quarter century.
Yeah, you're
and
dedicated.
none of those 20 million people should have died. I am pissed as hell at the
Okay.
healthcare system. And I think there should be a reckoning sooner rather than later.
I see your side of it there, definitely.
Now, one of the problems is that the people who go on dialysis are generally poor and people of color. So we're talking about essentially a wealth transfer from taxpayers who are spending $300,000 per dialysis patient on average. The money is going into the hands of hospitals and nephrologists primarily, and vascular surgeons. And the people whose lives are being sacrificed are generally Hispanics and blacks. Blacks go on the machine 5 times more than whites, and Hispanics 3 times more. So to me, it's medical slavery to suppress a cure for it or a way to prevent it. And this would never have happened in the 50s with Jonas Salk's vaccine. I mean, can you imagine still having iron lungs and polio wards in all the children's hospitals? But that's precisely what's happened for the last quarter of a century with dialysis.
And again, it's GENOMED.com. There's a ton of info there. You already have a little press releases in the media, I see there, but your publications as well. We got about 2 minutes, so a couple more questions in the speed round, but I want to give out the number again. It's 954-586-8058. It's Dr. David Moskowitz, internist, so internal medicine, nephrology, Margate, Sunrise. Why did I type Hollywood? You're over there too?
I lived there.
Okay, you live in Hollywood. That's how I know. I found you on LinkedIn. Well, Peter had found you, but I had found some more info on you on LinkedIn. I think it listed Hollywood, probably where you do your posting from, or like mine would be Boynton Beach. But again, genomed.com. Dr. Moskowitz, it's been fascinating and very interesting to hear this evening. So definitely check it out. I want to ask you one last question. Besides GenoMed and everything else you have going on, what are your hobbies and passions in life outside of medicine?
Well, I love my wife. I love grandchildren that we have
Nice,
over.
congratulations.
So we have one grandson in particular who comes over on Fridays. We're very happy to host them for the weekend.
Okay, that's nice. And again, I want to thank you for coming on the show. You're always welcome back on. Let's start this discussion again in the future and see where you're at with GENOMED. So thank you.
My pleasure.
I
Thank you,
appreciate it.
David.
We'll see you next time on the You and Your Doctor show.
Thank you for letting us share with you a longer and healthier lifestyle. If you have a doctor or are a doctor and wish to be on the show, call AMP2 TV at 866-244-5422, and we will put you on the air as soon as possible. Tune in next week for more information on living longer and having a healthier life.